Good afternoon, or good morning if you're in the West. My name is David Page. I'm the chair for this upcoming session on plasma supply in Canada. It's really an honor to be able to chair this session. I was invited over a year ago, and I've been looking forward for almost a year to be there in person and meet the speakers today and all of you. Unfortunately, we'll have to do this at a distance. We have a really esteemed panel from all over the world. We'll be listening to Johan Prévost, who is the executive director of the International Patients Organization for Primary Immunodeficiencies. He's been in that role and committed to the community for 19 years. He'll be followed by Sylvain Grenier, who is the director of the Plasma Protein and Related Products Formulary program at Canadian Blood Services. He's normally in Ottawa, but he'll be speaking to us from Brussels. Then Josh Penrod, who is the Senior Vice President and Head of Global Plasma for the Plasma Protein Therapeutics Association, which is the trade association for the for-profit companies in the plasma industry. And finally, Peter Jaworski, who is an Associate Professor of Ethics at Georgetown University's McDonough School of Business. He's actually a Canadian, but he's coming to us from Washington, and he's the author of Bloody Well Pay Them, the case for remunerated plasma collections. You'll have a chance to submit questions to the organizers, and they'll be sending them on to me, and we'll try to answer as many as we can. My first question, we'll see if it gets answered, is how did Whitney and CIPO manage to arrange the major announcement from Canadian Blood Services 2 days before their meeting? So maybe we'll find out how that happened. It's really quite a coincidence, but a happy one for this panel. And so without any further introductions, I'd like to move on to our first speaker, Johan Prévost.
Thank you very much indeed, David. It's a pleasure to be here. I'd like to thank the organizers, CIPO, for inviting me to address you in this session. So as you've heard, my name is Johan Prévost. I'm the Executive Director of the International Patient Organization for Primary Immunodeficiencies, or IPOPI. Been working in the field of rare plasma-related disorders and plasma products for over 20 years now. And for patients with primary immunodeficiencies, access to a stable and diverse supply of immunoglobulin therapies is absolutely vital. A large majority of our patients rely on lifelong immunoglobulin therapies to ensure that their immune system functions as it should and avoid recurrent infections, organ damage, and potentially death. Access to these life-saving therapies is therefore primordial for patients. Importantly, it must also be kept in mind that immunoglobulins are not generic medicines, nor are they interchangeable. They are biological products, and each patient will tolerate them differently, have different preferences that are all key to a good quality of life. This said, the field of plasma-derived medicinal products has witnessed recurring supply tensions over the years and last decades. Patient needs for immunoglobulins have grown significantly and constantly on a yearly basis, about 8 to 9%, notably due to improved diagnosis and new indications that have come on board. The supply of immunoglobulins is therefore intrinsically linked to the collection of human plasma, either recovered from blood donations or sourced directly from plasma donors and plasma donations. PID patients are extremely grateful to all donors, be they blood or plasma donors. This is something that my organization, IPOPI, has highlighted on numerous occasions. And we've been engaging with health authorities, regional and international institutions for many years on the topic of plasma collection and immunoglobulin supply. And this to ensure that patients are included in these high-level discussions and policy making. I think we've heard a little bit about the importance of doing so in the opening ceremony today. It's crucial to ensure that policies governing blood and plasma collection are patient-centered. Whilst ensuring the respect and health of donors, should always be a key priority of such policies. Ensuring patients can access their life-saving treatments should be given paramount consideration. If we look at the international level, there has been and continued to be a significant geographical imbalance in global supply of plasma. With over 65% of all world plasma collected in the United States. And this has resulted in a dependency of other countries on the US supply. And it argues for both more plasma supply, but also greater regionally balanced plasma collection. IPOPI, together with other plasma product users organizations under the PLUS banner, has advocated for progress towards a transparent, regulated, and well-tolerated framework for the coexistence of both voluntary unpaid blood donations and compensated plasma donations. A fact is that the large majority of plasma and the growth in plasma supply over the last decade has come from source plasma, mainly collected by the commercial sector. The COVID-19 pandemic has further exacerbated the situation as plasma donations have decreased sharply. Whilst we understand that plasma collection are on the increase, it is likely that the impact of this decrease in collection will continue to be felt by our patient community this year and likely for the year to come. IPOPI has just organized last week a roundtable policy meeting at the European Parliament to discuss immunoglobulin shortages across the EU, for example, where many IPOPI member organizations have reported the impact of the pandemic on their patients' access to treatment. So at this stage, more than ever, collaboration between all parties involved in the supply chain of these life-saving medicines is absolutely crucial. IPOPI has been calling for the coexistence of both public and private sectors and is encouraging public-private partnerships, including in low and middle-income countries, to ensure more is done so that each world region can collect more plasma. Plasma-derived therapies such as immunoglobulins are global medicinal products, and ultimately, patients will benefit from a global sufficiency in plasma products. Interestingly, during the first year of the recent pandemic, convalescent plasma and hyperimmune globulins were put in the spotlight. This was because they could have been life-saving treatments for millions of COVID-19 patients across the globe. For an organization like IPOPI, it was really inspiring to see the great collaboration between all stakeholders and from both the public and private sectors. And during this period, the focus was centered around saving lives with well-regulated, safe and effective therapies. The well-being and the lives of patients were the driver of these initiatives. And in Europe, ideological discussions have for a long time been perhaps slowing down progress. And it was interesting that during this period, these ideological discussions around whether to compensate donors or not were not the primary consideration. What patients with primary immunodeficiencies and other rare plasma-related disorders ask for is that the same approach is applied for them and their well-being. It's my pleasure to be here. I'll be very happy to participate in the discussion, follow the recent announcement in Canada, and I'm looking forward to a very interesting session. Thank you, David.
Thank you, everyone. So as David has mentioned, I'm Sylvain Grenier. I'm the director of the Plasma Protein and Related Product Formulary Program at CBS. What this is really, and maybe a bit of my background before we get even to the program, my training, my background, I'm a pharmacist. And before joining CBS 3 years ago, I was in charge of the drug plans of the Canadian Armed Forces. And the reason why it's relevant, it's really because since I've joined CBS, we are modernizing the formulary program so it looks more like how drugs are being covered on the various provinces. But as you know, at Canadian Blood Services, we do manage a national system. So when rules are applied, they're applied for the entire country except for Quebec because Quebec uses emacabectin. So if we look at the program itself, the formulary program, we have about almost 50 different products that we have there, including immunoglobulins, IVIG, and sub-QIG as well. And the way we determine which product gets into the formulary really comes with a partnership between Canadian Blood Services as the formulary manager to the provinces and territories who are the actual funders of the program. What CBS offers to the provinces and territories and also to the patients is really an end-to-end service. So we go from the collection of plasma. Already we've discussed it. There's the announcement that was released a few days ago from Canadian Blood Services about where we're going in the future with the collaboration with private collectors on top of what we are doing. So we do the collection. We don't do the fractionation, but we contract the fractionation out, which basically extract the various products, including immunoglobulin. We are not self-sufficient now, and it's going to take many years before we are self-sufficient. So in the meantime, the extra products that we need, we purchase from commercial products that are available from those companies. And the way we do that normally is through large tendering process, also known as request for proposal or RFPs. We then distribute the product as a wholesaler to all the hospitals in Canada, except for Quebec. And then we are the formulary manager. So what does it mean to be a formulary manager? There are more and more products coming on the market, multiple companies, and we have to determine what best mix of product is needed for the Canadian market. And to determine that mix of product, there's a lot of consideration we have to take into consideration. Things like, are there products that provide a clinical advantage versus others? Are there products that are safer than others? Are there products that offer better option, better convenience, better quality for the patients? Ancillary products to be included as well. And then what really is the impact when we look at security of supply, which we know in the case of immunoglobulin is very top of the list on making sure that the products are available for the patient. So we have to take all of this into consideration to determine the right mix of product that we carry on the formulary. And at the center of this, obviously, is to make sure that the patients get what they need so they have their life-sustaining and life-saving medication that is available to them. Since I started at CBS 3 years ago, the first milestone, the first major change that we did was the introduction of what we call the interim review process for plasma protein and related product. It's a joint venture that we've done with CADD, the Canadian Agency on Drug and Technology Health Assessment. That agency is an organization that reviews the science, reviews the evidence of the various drugs in Canada, and then issues recommendation to the provinces who pays for those drugs. So we're talking about the drugs here. The partnership we've done with them on the plasma side is that we follow a very rigorous process, very similar to what happens with the drug. So the evidence is being looked at to see if a new product does provide a clinical advantage or if there are safety concerns. Then after that, they will do what they call an economic model or pharmacoeconomic model, which will look at if there is a clinical advantage, how much is the clinical advantage worth it to be paid by public funds, and then they issue a recommendation. Part of that, they will also reach out to patients and clinicians to get their feedback to be part of it. Once the recommendation comes out of it, it's not the end of the process. CADD does not make a decision, they issue a recommendation. In that process, CBS takes that recommendation. We approach the patient groups. So in the case, there's a product right now that we're reviewing, IQVIA, which is a sub-QIG, which is mixed with a recombinant hyaluronidase, which allows for the sub-QIG to be given once a month. So in that case, when the recommendation was issued at the beginning of July, we reached out to CIPO, we reached out to other organizations, we reached out to clinicians as well to get an impact assessment from them. So basically, what would be the impact if the recommendation from CADD was to be implemented as is? So we're getting that feedback right now. In the meantime, we are working with the company that makes IQVIA to negotiate the best price we can negotiate. And when we conclude all of this, we will issue a recommendation to the funders, the provinces and territories, for them to make the final decision. And then once they make a final decision, we then introduce the product and then it becomes available. So that's one way of introducing product on the formulary. That process is really for new medication that has a difference, like quite a significant difference compared to what we carry on the formulary. So in the case of IQVIA, because of the addition of the recombinant hyaluronidase, we decided we would be going through that pathway. If it was just a plain sub-Q IG coming on the market, a new IVIG, well, that product would be reviewed when we do the RFP, where all products are being reviewed. So we've just concluded an RFP. The announcement of the result of the RFP will be coming in the next few weeks. And what we did is basically open that tender process for companies to apply and bid, and then we evaluated the various products. And the way we evaluate products when we do an RFP, we first look at the differences between the products, if there are any. We have a review committee, which includes representative from patient groups, representative from clinician groups, as well as people at CBS. And then when we score all the products, we compare all of the scoring against the price that was provided. So we're not looking just at the cheapest product. We're looking at the product that brings the most value for the price we're paying. And then we develop various product mixes, which then end up on the formulary. So you can see, to determine what products are available on the formulary or not, it's quite complex. There's two main processes. They're very similar in terms of making sure that patients, clinicians, and evidence is all taken into consideration when we make those decisions. And I think I'll leave it at this for now. And of course, I'll be more than happy to answer any question people may have. Thank you.
Hi, everyone. I'm Josh Penrod from PPTA, the Plasma Protein Therapeutics Association. I'd like to, first of all, start by thanking CIPO. Appreciate the invitation, thanking Whitney, of course, and of course, thanking David, our illustrious moderator, for today's discussion as well. And of course, my fellow panelists, I'm very much looking forward to this conversation too. So just quite briefly, I'm in my 20th year now at PPTA. We've had some organizational changes over the past few months, and I happen right now to be one of the 3 co-leads of the organization. So I have a pretty good understanding and relationship within the industry and members of the industry, and I have been around a considerable length of time during that interim. I should say too, just to manage expectations at the beginning, that I am legally restricted from making any type of forward-looking statements. I cannot make predictions. I can't comment on specific company products or company decisions, strategies, things of that nature. I'm happy to talk about things that can be sort of, I guess, considered industry-wide in their context and direction. So I understand that an audience such as this has a fairly wide spectrum of degrees of familiarity with what we would be talking about here. I'm not going to take anything for granted, but what I will do in the interest of those who do know well, I will try to go fairly quickly at fairly high level, but just for the sake of those who perhaps don't have a full picture of how the plasma products come to be. Johan said it at the beginning, immunoglobulin and other plasma protein therapies come from human beings. These are products that are fractionated from human plasma, which has been collected from a person. The person donating has been rigorously screened, assessed. The plasma has been tested. We also assess the donor for suitability, and what we mean by that is to make sure that they are healthy enough to donate plasma as well. And so once the plasma is fully tested and it goes into the manufacturing process, it goes through another series of tests and some significant steps of product purification and viral inactivation, other safety measures that are in place. The industry has a very, very long history, decades long now, of providing very, very safe products to patient communities all over the world. Also want to say too that my focus during my extended tenure at PPTA has been primarily on plasma collection, but I've also been involved in some of the areas on the fractionation side as well, particularly outside of the United States and Europe. My remit within PPTA also includes plasma collection in Europe, the United States, Canada, and elsewhere as the industry sees fit, to have me represent them in whatever context is necessary. So the COVID pandemic has been mentioned a couple times. I think I should probably just address that at first. Johan mentioned it too. There was in 2020 an approximately 20% decrease in plasma collections in the U.S. And there has been a slow recovery through 2021. I'm happy to say that from the backward-looking information that I've seen, and I don't have information quite up to today's date. I have data that is pretty up through the beginning of the summer of this year, and plasma donations have been accelerating through that time. So I'm very, very pleased to be able to say that. That being said, again, as Johan mentioned, there is a long lead time between plasma collection and the time the finished product actually can leave the fractionation facility. So what the industry has been doing in the interim, of course, during COVID itself, during the downturn, companies used inventory that they had on hand in order to forestall any problems in supply as much as possible. But over the past couple of years too, I can say that in the United States, for example, the industry has opened nearly 200 centers, in addition to what it already had in 2019. That's a significant increase, and it's a credit to the industry, and also credit to the regulatory authorities who have been able to work with industry insofar as getting these facilities inspected, licensed, and so on, to make sure that the plasma collected can be used as quickly as possible for products that patients need. So with that, I can say a note of optimism as we move away from the impact of COVID. With that, of course, always fresh in mind is the importance of continued vigilance on safety of plasma protein therapies. Of course, everybody by now has heard about monkeypox, and our experts within the industry in pathogen safety working group that we have are very, very much attuned to any type of emerging infectious disease. The surveillance systems are in place and are being used routinely. Anything new that comes up is assessed, and anything that needs to be addressed will be addressed in short order. As I mentioned, the industry has a long history of safety with regard to these products. And we do use compensated donations. We also use recovered plasma donations as it may be warranted. I should mention too that the safety of these products have been long attested to not only by the industry, but also by regulatory authorities such as the European Medicines Agency, the United States FDA, Health Canada, and so on. Along with the products, and that's the one end of it, and of course that's the end that I think is of most interest to members of SIPO and this community more generally. But we also have a plasma vigilance program wherein we have conducted and are conducting a number of studies over the next few years on donor wellness and donor safety. We have had a recent transfusion article published late last year. We have more on the way. We've had several prior to that. And all of these studies are designed to ensure that we know what's happening with donors, that we understand that the processes that are used are not harmful to donors, and that the process itself that the donor goes through is as pain-free and as inconvenience-free as possible. But at that same time, I also want to echo what Johan said at the outset too, which is that we need to salute donors for their commitment. It takes time to donate plasma via apheresis. It can take upwards of an hour for a repeat donor, someone who's used to and experienced in the process. It can take even longer for a first-time donor, 2 hours or more, because of the screening processes in place and moving through the steps that it takes to be a plasma donor for the first time. So all of that by background. I'm looking forward to participating in the discussion as well. So thank you very much for inviting me again, and bring on the questions.
Thanks for that, Josh. I want to thank David and Whitney and everybody at SIPO for inviting me to this panel. It's a real honor. I'm an ethicist. Sometimes I have to remind people that the objective of a system of plasma collection should be to collect enough plasma in order to meet the therapeutic needs of patients. This is the primary moral point of having such a system. The point of a plasma collection system is not to give people an opportunity to express our altruism. We don't lack for these opportunities. You can always give someone a hug or tell your friends or family that you love them. What we lack is medicine. The point of a plasma collection system is not to promote community solidarity or to give us yet another reason to be proud to be Canadian. There are other ways to promote solidarity or national pride, but there aren't other ways to make immunoglobulin. The point of a plasma collection system is not to provide jobs or financial resources for either unions or private industry. The point is not profit, and it isn't dues or a union monopoly on plasma collection jobs. Unfortunately, the discussions about plasma collection too often get stuck in discussing these other things. We talk about this issue as though the protagonists and the issue are donors and their altruism, employees and their jobs, unions and their dues, and companies and their profits. But these should not be at the center of our discussions. The main protagonists and the main issue when it comes to our system of plasma collection are patients and the therapies that they need. Right? This is why the right moral standard for evaluating our system of plasma collection is simple and straightforward, and it is this. Are we collecting enough plasma to ensure uninterrupted, safe, and sufficient access to quality of life improving and often life-saving therapies for every patient that needs it? Now, by this standard, Canada and unfortunately too many other countries besides, they have been failing their patient communities. Now, to their credit, Canadian Blood Services has announced a partnership with Grifols to collect plasma in Ontario and British Columbia. This will definitely result in more plasma collection, and maybe more importantly, I think it shows that CBS is listening to patients who have been calling for something like this for a very long time. CBS is targeting 50 to 60% self-sufficiency, but hopefully they will allow plasma collections far above this target. With half the population of Canada, Ontario alone could collect more than 100% of the plasma needed by Canadian patients. Now, Héma-Québec responded to the news of the partnership by telling the Globe and Mail that they are doing just fine without a private sector partner. They are collecting 30% of the plasma Quebec patients needed last year, and they are optimistic that they will hit their target of 40% self-sufficiency, maybe this year, maybe next year. But what that means is that Quebec is currently 70% dependent on plasma collected in the United States and is planning to be indefinitely dependent on American plasma collections for nearly 60% of their needs. How is this fine? This past week, former Attorney General Alan Rock also weighed into the discussion with an opinion piece also in the Globe and Mail. He said that we don't need to compensate plasma donors and complained about the partnership that CBS has created with Grifols. In his piece, he lauded Australia, New Zealand, Belgium, Italy, and France, as well as, quote, other EU countries, end quote, as doing just fine without compensation, managing to collect 50 to 90% of the plasma patients in those countries need. Now, I think the numbers are not quite right. For example, according to a 2020 Belgian publication, France was only 33% self-sufficient that year, while Belgium was 45% self-sufficient, not 50 to 90% as Mr. Rock had it. So some of these numbers are disputable, but in any case, Italy and France are, I think, unusual cases to cite. In Italy, you can get a paid day off work to donate plasma. Now, that would count as payment and be illegal under Ontario and British Columbia laws. Now, by our lights, Italy is a country that compensates donors. France is an unusual case because their publicly owned plasma company, LFB, runs 4 pay-for-plasma centers in the United States. Now, I wonder, would Mr. Rock be happy to see Canadian Blood Services open pay-for-plasma centers in Buffalo, Detroit, Seattle, or in Spokane, Washington? But even if we ignore all of these, I think, uncomfortable details, this still means that these countries are dependent on plasma collected in the United States for up to 50% of their needs. How are these low expectations fine? And why is paying Americans to donate plasma so much better than paying Canadians? Now let's go back in time just a little bit, shall we? Nearly 10 years ago. In 2013, so a year before Ontario passed the Voluntary Blood Donations Act, Dr. Graham Scher, the CEO of Canadian Blood Services, he explained in an opinion piece for the Toronto Star that, and I'm quoting here, a prohibition on paying donors for plasma for commercial fractionation use would deny patients access to these products both here in Canada and around the globe. When lives are at risk, he said, that's simply not an option. Now, how right he was. Back then, Prometic Plasma Resources and Canadian Plasma Resources were planning to open a total of 19 plasma collection centers. Instead, what we got were only 3 plasma collection centers because Ontario decided to pass the Voluntary Blood Donations Act and British Columbia followed soon thereafter. Now, they banned it despite overwhelming opposition from patients and from patient organizations like CIPO and the NRBDO. But patients and their therapies barely registered as a subject of discussion. Instead, the legislatures and the newspapers, they were full of comments about donors and their altruism, unions and their jobs, private companies and their profits. Had Ontario and British Columbia listened to patients, we would have been more than 50% self-sufficient in 2019, well on our way to 100% self-sufficiency. Today, we would have been just fine, but we're not doing just fine. In the European Union, it is Germany that is doing just fine. So is Austria and the Czech Republic, not Belgium, not Italy, and not France. Germany, Austria, and the Czech Republic are collecting more than 100% of the plasma needed by their respective patient communities. In Canada, meanwhile, it is Alberta that is doing just fine, not Quebec. Alberta repealed the Voluntary Blood Donations Act in December of 2020 and is on track to collect more than 250,000 liters of plasma by 2024. That represents more than 100% of the needs of Alberta patients. With half the population of Quebec, Alberta will collect twice as much plasma. Manitoba, Saskatchewan, and New Brunswick are also doing just fine and will each have plasma collections nearing or possibly exceeding 100% of the needs of their patient communities. And I think this is what we should expect. Mr. Rock and HEMA Quebec are asking patients to accept low expectations so that we avoid compensating Canadians while continuing to compensate American donors. We should not accept these low expectations. We should have policies in each of our provinces that will reliably result in 100% plasma collections, as in Alberta, Manitoba, Saskatchewan, and New Brunswick. Not 60%, not 50%, and definitely not 40%. We should have policies that allow for more than 100% collections. This would not only ensure against supply disruptions for our patients, it will also allow us to assist countries with plasma collection deficits. Countries like Australia or New Zealand or Belgium or Italy and France. Because that is the point of a plasma collection system. And that's what it means to put patients at the moral center of our discussions. We should demand and we should expect no less. Thank you very much.
Thank you to the speakers. I think we'll bring all the speakers back. Here they come. Great. we've gone a little bit over time, so I'm going to not allow the speakers to ask each other questions, but I'll launch right into my question. So my first question, I think we've talked several times about the changes that were announced this week. Sylvain, would you be able to summarize in a minute or two what's changing and what's not changing in the CBS context?
Yeah, I can do that. The information that was shared is really the information that I have as well, because at CBS, there's multiple teams working on the plasma initiative, and my team is more focusing on the products at the end than the collection of plasma. But what I can share is Canadian Blood Services will continue, and you know that over the last few years, we have opened some plasma collection centers, and we have a plan to open more over the next few years. So we will continue to do that, and we will continue to do it on a voluntary basis, which is the model that CBS still believes in, that we can make work. So this will be happening. There's no change there. We have partnered with a private collector and fractionator, which is Grifols. It's been announced. And Grifols will also collect plasma in Canada for Canadian Blood Services, and they will follow their own model, which is a paid model. So they will be paying their donors. And one of the points that is very key that has not been mentioned yet in this conference is that that plasma that will be collected by Grifols and CBS eventually will be fractionated in Canada. In Canada right now, we do not have an operational fractionation plant. All the fractionation is happening in the US and in Europe. Grifols does own a fractionation plant in Montreal. I don't have the exact dates, timing. It's in a few years from now. It will be operational. And at that point, our plasma will not only be collected in Canada, it will be fractionated in Canada. And really what drove us to do all of this was all the risk that happened with the pandemics, the closing of the borders. So the collection of plasma is one thing, but the fractionation is also important. So in a nutshell, that's really what we are doing with Grifols. We are not changing our model. We are partnering with them to make sure that more plasma is collected in Canada with both models, and that plasma is fractionated in Canada for use with Canadian patients.
So Sylvain, that's great news, and the patient organizations and our coalitions have been calling for this for a number of years. Very last quick question though, in the shorter term, is there, and this is a question from the audience, is there any risk of shortages of IG in Canada at the moment?
At the moment, with the inventories that we have, we don't foresee any risk of shortage. What happened at the beginning, before the pandemic, we were looking at increasing our inventory just because of the stretch that exists right now around the world about the use of immunoglobulin. When the pandemic hit, we really worked closely with all our vendors to make sure that they would be able to continue to the commitment that they have. Because remember, the way we procure plasma in Canada is through those tendering process. It's a heavy process, but those process also allow some guarantees that we're going to get products. So once we were able to see the challenges of the vendors, because as it was mentioned by Josh, they lost some plasma collection. So it's not that they wanted to stop producing it, they just didn't have the raw material anymore. So once we had the discussion with them, we were able to make sure the needs would be filled. And during the pandemic, the use was much lower than anticipated. So our inventories right now are very well.
Thank you, Sylvain. My next question is for Johan. One of the critiques that we've heard numerous times in Canada is it's not that there's not enough plasma to make immunoglobulin, it's that we're using too much immunoglobulin. We're wasting it because we're using it indiscriminately. From a worldwide perspective, can you comment on that? Certainly I know that Canada uses a lot more immunoglobulin per capita than some other countries.
Yeah, thank you, David. It's a good question. It's something that has been brought forth also in some of the discussions in Europe. Obviously, commenting for the primary immunodeficiency, patient community, I think the solution, moving forward is collecting more plasma. It's not looking at ways to try to decrease access to immunoglobulins. I mean, certainly if you look at the gold standard approach for PID patients, having an appropriate dosage of immunoglobulins is highly important. And in fact, what we have seen, and part of what we have discussed in our forum at the European Parliament last week, is that some of the measures that were put in place in some European Union member states as a result of the COVID-19 impact on supply, were to lower dosages, were to distance infusions from one another. And that has resulted to a clear impact on the quality of life of our patients. So, as far as our PID community is concerned, for sure, this is not an approach that we would support. And I think the answer is really collecting more plasma.
Certainly, we've heard from the clinicians in these discussions here in Canada that the clinicians do not think that there's overuse or wastage. Peter, can I ask you a question? Perhaps a bit provocative. Is it more ethical to pay donors or not to pay donors?
I think it should be up to the donors. I think it's fine if donors choose to donate without compensation or with compensation. I think the real central question, though, is what sort of system is going to ensure that we get enough plasma? And I think at this point we have more than enough evidence to suggest that there are going to be people that will donate plasma without being compensated. We have a certain number of people that are dedicated to do that every single year, possibly every month. But at the same time, it's the compensated system that generates the vast majority of the plasma that patients rely upon. So I think it's important to go ahead and allow compensation, as Canadian Blood Services, to their credit, is doing in Ontario and British Columbia with the partnership with Grifols.
Thanks. My next question is for Josh. Another criticism of the compensated model that we've heard is that it's exploitation of the vulnerable. Could you please address that and talk about, who are the typical donors to the companies that you represent in PPTA?
Yeah, I think that if you want the more technical response, Peter would probably be the better person to talk specifically about some of the ethical considerations that go into exploitation. But what I can say is that, just taking the United States as an example, where you have a base population of more than 330 million people, we have just over 1,020 plasma centers right now operating in 44 different states or thereabouts, I think. And as you pretty much incorporated in your question there, David, donors are very diverse, and donors can be anything from someone who is part-time employed only, up to somebody who is a white-collar worker. I have been to more than, I think, latest count, about 175 different plasma centers over the course of my career, in a bunch of different countries and states. I've been to plasma centers in China. I've been to plasma centers in Florida, Canada, Germany, Austria. And so whenever you're talking about the plasma center, it's very, very, very community-based. And plasma centers are a diverse group of people. And I think that is also a message of great value to the community of SIPO, where you do want a diversity of donors giving their plasma for purposes of the antibody panel that would be present in the finished products. So there's no one right answer to who the donor is. The donor can be a teacher. The donor can be an attorney. The donor can be a student. The donor can be any one of us. And I think it's important that be kept in front of mind. Thanks.
Another question for Peter. So again, I'm focusing on the criticisms that we've been hearing. They've been very vocal. So the critics say that this new agreement between CBS and Big Pharma, they call it, is a threat to Canada's universal healthcare system. That it's privatization. Can you comment on whether you agree or not with that statement?
Yeah, I disagree completely, David. Thank you for that question. It's as much a threat to Canada's healthcare system as buying aspirin from Bayer is. Bayer is a private for-profit company. That's how we get that medicine. We make medicine from the plasma that we collect. Canadian Blood Services then delivers that medicine at no cost to the patients, right? This is compatible with our universal healthcare system. David, if I might also chime in on the question about exploitation, because I would like to answer that. I have a much longer article that's available. If anybody wants to email me, I will send you an early draft of the chapter for a book that's coming out on exploitation. It's precisely on this topic. But in brief, I can say the following. To make a case of exploitation, you have to demonstrate that there is too much risk for too little reward, or you have to demonstrate that there is an unfair division of the benefits from trade. We all know that plasma donation is not risky, and the amount of reward that donors like myself receive for donating plasma is about $50. It takes, as we've heard, about an hour to an hour and a half to donate plasma, so it's not too risky. The reward is not too small, and it isn't unfair either because donors receive somewhere around 20% of the total revenue per liter of plasma. And by the way, I should say, to tie it back to the first question that you asked me, if $50 for a donation of plasma is exploitative, meaning it's an unfair division of the benefits of trade, how much worse is paying people $0 for a donation of plasma? So I don't think it's exploitative, and I'm not suggesting that the non-compensated plasma donation system is itself exploitative, but I think you could make a better case that it is exploitative than that compensated plasma donations is. Thank you.
I'd like to go back to Johan. We have a follow-up question from the audience. You mentioned that you don't think there's overuse. Canada has perhaps a higher per capita use across the board for IG. How can we explain the higher use? Is it possible that we're actually doing a better job in diagnosing patients here and treating patients here than in some of the countries where the per capita use is much lower? From a European perspective, I'm sure you've seen countries where there's much less use of IG.
Absolutely. I mean, this is something that is seen in the European Union between different countries, and I think for sure it indicates that patients in Canada are probably receiving more immunoglobulins that is needed than in other countries. But I think to tie it back to your first question, often these discussions about decreasing the use of immunoglobulin therapies are linked to the argument that perhaps we don't need to put as much effort in collecting more plasma. And I think, from an ethical standpoint, especially from our perspective as an international organization, when you know that some world regions have far fewer, and smaller access to immunoglobulin therapies than others, when you know that if we compare world region, probably North America consumes about half of the world's immunoglobulins. Europe probably about a quarter, and then think about the other regions. Think about Asia, which consumes about 20% of immunoglobulins, but covers about 65% of the world population. Or think about Latin America. The Latin American population is actually bigger than the European population, and they have about 4% of the worldwide available immunoglobulin. So I think it's absolutely irresponsible to link these attempts to reduce the use to arguments for minimizing the need for more plasma. I think there's an absolute need at the global scale for more plasma. We should be collecting more, and we should make sure that patients, wherever they are in the world, can access more immunoglobulin. So I think we can't be self-centered. A region cannot think only about its needs. I mean, what would happen if tomorrow, the US supply was affected, let's say, by a new virus that would affect plasma supply. Now in Europe, we would say, well, that would be so bad for European patients because we're so reliant, on US plasma, but it'd actually be worse, for US citizens. So I think, what we've been pushing for, this concept of more regional balance in plasma collection and global sufficiency is really the way to go. And I think we need to look at two scenarios. There's a scenario where there's enough plasma and there's enough immunoglobulins, and that's the perfect scenario. And a patient in China or a patient in Canada or a patient in Austria, they should be able to access the immunoglobulin, that is tailored to their needs. But when there's that situation with shortages or one region is impacted, having this a regional balance around the world will help greatly in minimizing these access issues. So I think it's absolute nonsense, to push for less consumption in immunoglobulins, and especially when this is tied to plasma collection and attempts to say that we don't need more plasma.
I want to ask the last question to Josh, and I'll give everybody a chance to sum up your final thoughts. But Josh, the big elephant in the room often that is raised is safety, and we're told, voluntary donations are so much safer than compensated donations. Could you comment? Say, let's look at the last 25 years, the number of HIV, hepatitis C, and hepatitis B transmissions through products supplied by the companies in PPTA, and compare that to the products supplied by the not-for-profit sector. Is there any difference in the safety and quality of these products?
Over the past 25 years, there's been no transmissions of HIV, HBV, or HCV, the relevant pathogens that are the typical measures that are used for quality and safety of plasma-derived therapeutics. I don't know the numbers off the top of my head for the transfusion community, but I think it's important to draw that distinction in terms of what we're talking about, particularly in Canada, because this line gets blurred, unfortunately, too much, where there's this conflation of transfusible products and plasma that's in fact used for further manufacture. And the entire system that's set up for fractionated products for patients within, for example, the CPO community, is predicated on the use of plasma specifically for further manufacture. And it has nothing to do at all with the transfusion community or transfusion medicine or emergency medicine or anything that would be utilizing, say, packed red blood cells for a trauma patient or a surgery patient or anything like that. Instead, the plasma that's used should be thought of as a part of an extensive value chain that incorporates many, many different inputs from many different industries to deliver an extremely pure finished product that has a high level of efficacy for the patient community for which it's intended. I don't know if that's completely responsive to your question.
Well, I think the point is, which really needs to be clear, is that whether the donations are compensated or not compensated, the plasma-derived medicinal products that come from those donations have a perfect safety record over 25 years.
Yeah, I can just emphasize that a little bit. I mentioned that in my little introduction that there's a 2002 statement by the EMA noting the equivalence of safety of products made from either compensated or non-compensated plasma. It made no difference more than 20 years ago, and it doesn't make any difference today. And I think instead that the focus, as it always is with the industry, the industry's pragmatic one. If the industry can use plasma from a non-compensated donor or a compensated donor, so long as it meets the scientifically needed requirements and medically needed requirements for the plasma to be used in further manufacture, then it's fine. There's no ideological commitment one way or the other. It's whether the plasma can be used, and the industry is always going to be favoring whatever provides greater access to patients.
I'd like to give everybody a last chance to make a final comment, if you have one, in 60 seconds or less. And let's start with Johan.
Well, thanks again to the organizers for inviting me. I was very interested in what my co-panelists had to say, and very interested in how the situation is developing in Canada. I think it's a step forward, certainly something that we've been pushing for here in the EU, is for a change of approach in how the EU as a whole approaches plasma collection. I think it was Peter who mentioned about the few European countries that have been more successful at collecting more plasma, and that's Czech Republic, Hungary, Austria, Germany, collecting up to 3 times more than other European countries. And I think they've been able to do so because they have been accepting and they have accommodated the coexistence of both private and public sectors. So I think these types of partnerships are needed. We've been, trying to collect more plasma just based on one sector in the EU since the beginning of my career in the early 2000s, and it hasn't produced more plasma collection in the region. So I think Canada is moving in the right direction.
Thanks. And Sylvain.
Very, very quickly, I think with the announcement that CBS did with the partnership with Grifols, it does demonstrate that we are serious about increasing the plasma connection. And ultimately, what we want to continue to achieve is to make sure that no patient go without product. So that's really, I would say, the statement I would finish with. Thank you.
And great timing. Josh.
Look, no, just thanks again to the organizers, and thanks to my fellow panelists for all of the good commentary that's been made, and thank you, David, for the excellent questions.
And Peter, final comment.
Yeah, I just wanted to end on a note of optimism. Sylvain mentioned it already, but I think the partnership with Grifols is a really good step forward. I'm really happy to see that. I'm really happy to see CBS go in that direction. I'm also optimistic globally. Josh mentioned that there are 200 new plasma centers in the United States. I envision further expansion in the United States. But also Egypt has created a public-private partnership also with Grifols. Romania is on track to create a similar kind of partnership. There are some discussions in the European Union that might result in greater plasma collections. And so while I think this year and next year things are difficult, I'm optimistic about the future, and I'm hopeful that we will collect more plasma all over the world.
Thank you to the great presentations and answers to the questions. I think we've covered the topic quite well. We've talked about safety and supply, and those really are the two key issues. Safety, I think, has been well covered over the last 25 years, but lack of supply is a safety issue, and so it's really good to see the progress that's going to be made soon here in Canada. So again, thanks to CIPO for the invitation, the chance to lead this discussion, and wish you a great rest of the conference. Take care.